Good afternoon, everyone. Welcome to our Back to Basics webinar series. For those of you that have joined us before, we're glad to have you back. And if this is your very first time joining this webinar series, welcome. We are also glad that you've made it here today. My name is Andrea Boucher with Superior Health Quality Alliance Chronic Disease Management Team, and I will be your facilitator for today. We'd like to ask you to please take a minute and enter your name, your organization, and your role in chat, so that way we know everyone who is joining us for today's session. Today's session is part of a webinar series. Our webinars are on the third Tuesday of each month at 12 o'clock Central, 1 o'clock Eastern. On this slide, you can see some of our future topics that we will be covering. Our next session next month will be focused on part 2 of end of life and advanced care planning, as we will be covering that topic today. And in June, we will be covering nutrition and have a guest from Second Harvest with us. And in July, we will be covering tobacco cessation. So just wanted to note that this schedule could be subject to change if there are some time-sensitive information that comes up that we want to share with you all. And we always welcome any feedback from you all on topics that you would like to hear about. So if you do have any suggestions or recommendations for any of our future sessions, we would love to hear from you. So you can feel free to chat any of the Superior Health team members and ideas that you might have. But with that, I am going to turn it over to our presenter today, Rachel Dibble.
Hello, everyone. My name is Rachel Dibble. Today we'll be discussing Advanced Care Planning 101. My background is palliative care and hospice care. So advanced care planning is really the cornerstone of those specialties. So it's a big topic. I'm excited about this talk, and I hope you all are able to take away some learnings. So the learning objectives are understand the difference between the different types of advanced directives, enhance understanding of the individuals who should have an advanced care plan, examine advanced care planning from the patient and the provider's perspective, review the physician orders for scope of treatment, otherwise known as post-form or PULSE, the purpose and how to use the instrument through the continuum of care. Next slide, please. So our first polling question, so I can get a sense of experience in advanced care planning. So do you have any experience with advanced care planning? Just simply check yes or no. Okay. Think everyone has enough time? Great, wonderful. Thank you very much. Okay, next slide. So what is advanced care planning? So this is really just the overarching umbrella term and definition of advanced care planning given by the National Institute of Aging. So advanced care planning involves discussing and preparing for the future decisions about your medical care if you become seriously ill or unable to communicate your wishes. Having meaningful conversations with your loved ones is the most important part of advanced care planning. Many people also choose to put their preferences in writing by completing legal documents called advance directives. Next slide, please. So understanding the actual definition of advanced care planning, we look at it also as a process. Advanced care planning, if you take away anything from this talk, understand that it is not this is a term that I have coined, a one and done situation. This is a continual conversation with your patient. So advanced care planning is a process that supports adults at any age or stage of health that assists in understanding and vocalizing their personal values, goals of care, and preferences regarding future medical treatment. This is a continuous, again, it's a process and a continuous conversation as health statuses change and attitudes towards end of life may change. So I'm going to stop right here because this is the crux of it. So again, advanced care planning is the process, and what we're here to do is to support the patient. We also, as providers, or anyone in the medical field, and that it is anyone touching a patient or face-to-face with the patient, and that includes custodians as well. Often patients talk to people they see daily and have a conversation with. So that custodian may know something, for example. But again, and that's how you figure out the information that that patient is needing more support. So that's how you support them. In any stage of their health, that is really specifically targeted towards chronic diseases. And they need to understand and vocalize back to you their understanding. Oftentimes, you will ask a patient, do you understand the chronic diseases you have? And they'll say often, I know I have a lung problem, or I think I have that sugar issue. That's when you stop and explain, for example, diabetes, chronic kidney disease, COPD, emphysema. They have to understand the disease state, where they are in the disease. Most importantly, out of all of this is what is their goals of care and preferences regarding future medical treatment. And goals of care does not really mean what you want or don't want. It's the kind of life you want to live with the chronic disease and years left. So those goals of care fall in the categories of comfort, longevity, comfort or longevity. And then that kind of tells you what the patient's goals are. So this is a continuous conversation again. So this slide is of the greatest importance in the talk. Next slide, please. So here it is explained. And this is really the technical aspects. This isn't kind of the nuances and the conversation and how to go about it. This is really the nuts and bolts. And in part 2, we'll get more towards the patient-centered care of this. So advanced directives are legal documents that navigate medical wishes when the patient is unable to communicate his or own wishes. And that's what we know as just lay people. You know, living wills, for example. Those are the wishes that you want if you can't make decisions. So the two most common are living will and durable power of attorney for healthcare. And that's your POA, and it's durable, meaning you and your POA work together, and when you can't make decisions, the POA does. So technically, those are the big two explained. Next slide, please. So a living will. So this is a legal document. Wishes are made by the patient, and common medical treatments or care are made. So a living will is a wonderful instrument if it is not an acute situation, or if every provider has the living will and it is noted in the chart what the patient wants if the event happens. Sometimes and oftentimes these documents can't be found. So by default, EMTs, or when you call 911, etc., if someone does not have a heartbeat, they're going to do CPR. They have to legally. Again, this is why living wills, other advanced directives have them accessible, particularly for providers. And when you're looking at chronic diseases, the event is going to happen. So it may happen in a year, it may happen in 2 years, but it's going to happen. That CHF is going to be exacerbated. So we have to get ahead of the ball, the 8 ball here, and explain what's happening, risk, benefits, and what do you want when the event happens. Next slide, please. The durable power of attorney for healthcare, and here's the actual definition. Durable power of attorney for healthcare is a legal document that names your healthcare proxy, a person who can make healthcare decisions for you if you are unable to communicate these yourself. So your proxy, also known as your representative or surrogate or agent or POA, if you would like, they understand and are familiar with your values and wishes. A proxy can be chosen in addition to or instead of a living will. So what that means is that person knows exactly what you want. I suggest having things written down. Things get hairy in situations. So having a healthcare proxy helps you, because you can do this collaboratively, plan for situations that cannot be foreseen, such as a serious car accident, stroke, particularly in chronic diseases, that an advance directive is very helpful with stroke and power of attorney. Next slide, please. So here are the types of advance directives. So a do not resuscitate order, DNR, is an advance directive. A DNI, do not intubate. DNH, do not hospitalize. Out of hospital DNR order, meaning you're out of the hospital, you're at home, you've had a heart attack because you have chronic, you have congestive heart failure, and you're at home and you're able, and I will tell you how later on in the talk of how the 911 EMT professionals will know and where to look for that DNR order. Then we get into physician orders for life-sustaining treatment. This is your POLST form. It's called different things in different states. So medical orders for life-sustaining treatments, MOLST, and then physician orders for scope of treatment, POST. They're called different things in different states, but they are nearly exactly the same form. Next slide, please. So who needs this? So patients who need it, actually need it, advanced care planning, are those that are chronically ill. So like I said, the provider at diagnoses starts this conversation because you know the trajectory. And this is when you start bite-sized pieces for the patient to understand their trajectory, for them to make decisions. You are the messenger with the information at hand so they can make an informed decision, particularly when they have a new diagnosis. That can change everything. Fine, they have CHF. Now they have stage 4 lung cancer. That changes their advanced care planning totally, because 6 months ago, they didn't have the cancer. So maybe they want DNR, DNI, DNH, the whole kit and caboodle. They want to die at home peacefully. Great, we know that because we've diagnosed or started the conversation on diagnosis, and we're updating. Medicare makes us update every year, and I highly recommend after hospitalizations and new diagnoses. Palliative care. This is a patient technically who has 1 year or less to live. Palliative care, that is when it's recommended or stated that they actually really need it. Palliative care, though, starts at diagnoses, because palliative care is symptom management until they get through their disease and they need or will or don't want to transition to hospice. Again, that is the plan, their plan, that we walk them through the trajectory of their disease. So I want to make a big statement about palliative care because I believe it's defined, or it's a different thought in people's head. This is basically that period before you feel great, no chronic disease, then you got to capture that time between chronic disease and decline, and then go to hospice. And that palliative care scope, again, that can be 3 or 4 years. I mean, but 1 year or less, they need that support. Advanced age, hospice patients in particular. This is kind of the last shot. You would be surprised how many people go to hospice without advanced care planning. So that means people don't know the patient's wishes, how they want their end of life to look like. Medical crises is the other one. Next slide, please. So disease trajectory. I know I have used animation, my arms, but here is the actual slide. And I've used this slide for probably 15 years because it is so accurate. And what happens is the usual trajectory, meaning no hospitalizations for chronic diseases, is that green line, right? And when you have access to early diagnosis, advanced care planning, and you understand the socioeconomics or the SDOH or health equity of patients, you are able then to position them disease-wise where they need to be. Is it palliative? Are they still in primary, etc.? But the important piece here is that the slope goes down. And what happens with hospitalizations without advanced care planning They call 911, they go to the hospital. Potentially that person didn't want to go to the hospital, but that's what happens by default. And the squiggly line, if you can see, is the patient with their chronic disease. The green line tells us they're going to decline, but because we don't know what their wishes are, they're going in and out of the hospital. Those are the acute admissions: inflammatory insult, delirium, poor recovery, etc. And then the pathophysiology, the body decreases, frailty, disease, symptoms. Again, palliative care deals with that. So when you look at someone with chronic disease, the decline is going to happen. Do they want to go in and out of the hospital? Do they want to stay home just with palliative care perhaps, or no? It's all up to them, for them to understand the lay of the land of their disease, to then facilitate the conversation and the decisions that go in with advanced care planning as a whole. Next slide, please. So what is a PULSE form? And I kind of want to change gears here. Yes, it is an advanced directive. Yes, it is a part of advanced care planning. But the National PULSE program, the history of it, or the background rather, started in 1991 in Oregon. And this is when all excitement in Oregon was happening. And this is what came out of it. So they understood that the patient preferences for end of life were not constantly or consistently honored. I think we've all experienced that. So the thought behind building the PULSE was, we realized with existing advanced directives were inadequate for patients with serious illness or frailty who frequently require medical care. So what that is that's the chart, the graph slide before. So we have serious illness, chronic disease, frailty. So we have the green line going down, but we don't know what the patient wants. So they're going in and out of the hospital. Then if we were to connect the dots further, going in and out of the hospital actually contributes to mortality and to frailty and to debilitation. So the idea there, particularly with hospitalizations, we have to know with the patient, if that is their wish, do they want to do that? So stakeholders then developed a tool to honor patients' wishes for end-of-life treatment. And this is what happened. In 2004, the National PULSE Paradigm Task Force, the website, the resource at the end is wonderful. It implemented standards for this form and the programs to assist states in developing the model, the process, the education. Next slide, please. So, and here is the QR code for the actual form if you would like to see it. So the difference between this and a living will, though they're all advanced directives, is this PULSE form isn't actionable. So actionable, meaning we do it. Transferable, meaning this form goes from home to the hospital, hospital to rehab, rehab back maybe to a nursing facility, back to home, revised because we have probably new diseases, etc., right? And this form is accumulation of a shared decision-making process between the patient and the provider. So this form identifies the specific disease, prognosis, treatment options, including benefit and risk, patient shared values and beliefs, goals of care, provider and the patient have to sign it. That's the difference. It's the provider. So what that is a medical order. So the only people that can trump that is the patient to change it or the POA. So that is different. So when that PULSE form goes into the ER with that patient, it is an order. And just an anecdote with community patients, our process was we had it taped on the window, or the refrigerator rather. If the patient went to the hospital, they taped it to the patient. So it was not missed. And that was a process that we developed, for example. So again, these are transferable. That's the key. And they're orders. So they're different than what the patient It's an order. And so that ensured patients' wishes were followed. Next slide, please. So the PULSE form versus advanced directive, we discussed it a little bit, but again, The clinical experience and research demonstrate that advanced care directives are not sufficient to ensure cares of goals of patients with serious advanced illnesses will be honored unless that PULSE or that transferable medical order form is completed. And then you have the advanced care plan. The advanced care plan not only identifies the surrogate or POA proxy or agent when the patient lacks capacity, but provides guidance. This is the guidance, opposed to the order, the guidance for the surrogate and provider on the desired treatment plan. So those are the differences. Next slide, please. So I have two case studies, and these case studies both show extremes. We don't have a lot of time, so I will actually just go through this and give you the highlights. And then afterwards, we'll discuss a little bit if time permits. So advanced care planning, case one. So here is a 79-year-old male. He presents to the ED. He's had a dry cough for 6 weeks. He complains of some fatigue and malaise. The cough has been non-productive, and patient states he's had no fever or chills. And in fact, he's able to go fly his airplane and just passed his FAA pilot's physical with flying colors. But he did comment that he just didn't feel right. So he went to urgent care and was prescribed Levaquin 750 once a day for 7 days for cough, which was interesting. Antibiotic for cough. Okay. And it subsided somewhat. So maybe there was a little bronchitis, pneumonia. Okay. So the cough was still there when he returned to the ED 3 weeks later and was prescribed Levaquin again, once a day, 7 days. He came back for a checkup due to some shortness of breath, but otherwise feels fine. His daughter, driving from Nashville, requested he return to the ED. So COVID-19 restrictions apply. And he states, I don't understand. I felt nearly perfect 2 weeks ago. His prior medical history is diverticulosis and BPH or benign prostate hypertrophy. So keep this in mind. Let's go to the next case, and then I'm going to stop. So here is advanced care planning for case study number 2. So this 83-year-old, very frail white male presents to the ED after 6 hospitalizations in the last 6 months. For the last 5 years, he has complained of significant weight loss, more than 60 pounds, feeling weak, hypotensive, and has had multiple falls. He has had an endocrinologist and an oncologist. All diagnostics yielded negative results for cancers. A bone biopsy yielded negative for cancer 2 years ago. His last 2 hospitalizations, he presented with pleural effusions and a small pericardial effusion, etiology unknown. He currently has acute respiratory failure and is hypoxic at 80%, according to the patient who took his O2 sats at home. His daughter is present to provide the medical history. So his medical history is diabetes, chronic kidney disease, stage 3, hypertension, pacemaker, myocardial infarct, or MI, and arrhythmias. So when we look at those 2 cases, who should have an advanced care plan before these things happen? You can just throw it in the chat, case 1, case 2. I'll wait just 30 seconds or so, and then I'll fill it in. Aha, exactly right, both. Both should because of age. Case study 2 in particular because he had chronic diseases. Now, how this played out with advanced care planning is the 79-year-old who had the little cough, but he was 79 years old, no chronic diseases. This person did not have advanced care planning or an advanced care plan, did not have a POA, had no directives, had nothing. He's in the hospital. He is then in acute respiratory failure. He is able to talk though. No one talks to him about who's your POA, your lungs. Looks like we've got a lot of inflammation. We might have to intubate. This is what the trajectory looks like. What do you want? That did not happen for the 79-year-old. So the POA then made the healthcare decisions the best that she could because she did not know what he wanted. Case number 2, this 83-year-old man He did end up having cancer, believe it or not. However, he had these chronic diseases for the last 10 years. No one talked to him about his chronic diseases, the decline of his kidneys as they're getting worse, why now he's having heart attacks because of his hypertension, CHF, etc., kidney disease, hypertension, all of those things, chronic diseases. Yet he did not know any of this, nor did anyone explain the trajectory. He understood health-wise where he was. No one diagnosed him. They couldn't for whatever reason, but he knew he was going to die because of how he felt. So he went, had an ironclad will, had 2 POAs, had a living will, had a post form. And when all of this happened, the decisions that we didn't have to make decisions as a family, or that family rather. And it was a much better death. It was peaceful. There was no discord with the family. And it was a very different situation in both of these cases, simply because of advanced care planning. The outcomes were the same, which was death, but how we got there was different, very different. Next slide, please. So how to begin the conversations, and we will get more into this in part 2, okay? So how do you talk to your patients? Having the difficult conversation. It is difficult, but if you do it in bite sizes, it supports the provider and the patient. Understanding the patient goals of care. Do you just want to simply be here? You don't have to function, but you just want to be on the earth. That's longevity. Or do you want to function, do ADLs? That might be a goal. Or do you just simply, you're tired and you want comfort? You're tired of the hospitals, you're tired of the doctors. And people get there after they've been in and out and in and out, but they don't understand their disease trajectory and that they should have had some advanced care plan. Begin the conversation at diagnosis. Continue the conversation and revise as needed. So again, more to come in next session. Next slide, please. These resources are great. There's a ton of them out there. These are the ones that I personally recommend that I think yield very concise, wonderful information. The ones I will point out is CAPSI. I believe everyone in advanced care planning, chronic diseases, it's a wonderful resources with CME, all sorts of things. Then, of course, your PULSE portable orders for medical, serious illness, or frail individuals. This is your PULSE paradigm. That's also in the deck. The Conversation Project is a wonderful tool. And then the 5 wishes. And I'm going to go, these are my resources for the next session. So I will highlight some of these things. Next slide, please. So, any questions or comments, experiences, stories, anything? It's a big topic.
If you have a question, you can either unmute and ask or share your story, or feel free to add it in chat.
I was going to say, Rachel, what others are thinking of their questions. Maybe I think I heard you mention, and I've seen this happen before too, with POAs or powers of attorney. I thought I heard you say that the one gentleman had 2 POAs, and I've known families too where they've had 2 separate people listed as their POAs. But I've always wondered, is that, the way to go, or is it better just to have one person?
So I will see, let me speak clinically first. I think it's always a good idea to have 2, because when the event happens, you don't know who's going to be alive, particularly if they're elderly, meaning one POA dies and the other one is there. You can have 2 joint at the same time. Some people do this, and I think it's really a family dynamic situation. Personally, for me, as a person. I have one. But that puts me in a vulnerable position. But I do that because it's not that I don't trust people, it's that I don't want any yang. I want, so that's my personal, but technically you can have two. Or you can have a succession if you would like. Does anyone have any experience with the post or most forms or filling them out or seeing them or being a receiver of one? Has it helped? Do you have an opinion about them?
I don't mean to be the one to keep talking all the time, but I was just gonna, no, I have experience. Yeah, I am a clinician, but I also have experience with it from the person, the family member side of it. And I personally thought that, I think they're very helpful. I think it starts the conversation, it makes people think about things and, if they hadn't already put together like an advanced directives, I find them helpful.
And I will speak from experience on it. I have seen a lot of plans of care completely do a 180 because we found the post or pulse or advanced directives. It really changes the care given to the patient.
There is a reminder in chat from Casey that April 16th today is National Healthcare Decisions Day. So very timely to have this conversation and share this information. So thank you, Rachel. All right. I don't see any other questions or comments in chat. So Rachel, do you have any other comments or anything else to share?
All that I have is, again, next session, again, I think we'll really operationalize it and make it more so you understand how that process will work. And again, I really encourage anyone with even just an elderly patient, 9 times out of 10, they have a chronic disease. And we need to lift our people up and give them the dignity of how they want to pass to the other place. So I'll leave you on that, food for thought, and you're really doing them a service. As hard as it is a service to them, and the family will appreciate it so much after the fact. So I'll leave you on that note. Take care of everyone and have a great day.
Thank you, Rachel. Just a couple of final housekeeping items. Again, thank you, Rachel, for your very timely presentation. Looking forward to hearing more in part 2 in our next session. But before we go, we would love to get some feedback from you all. That feedback is really important to us. It helps us to develop our future content and gives us some ideas on what you're looking for in future learning sessions. So if you could please take a moment to complete our evaluation. We're putting the link in the chat for you. It should already be there. So please go ahead and take a moment to complete that. And we do have 2 final polling questions for you for this learning session. So if we could get those launched as well. And I believe it's on the next slide here. So here is our final polling question for you all. If you could take a moment to fill that out once it's pulled up. And I'm not seeing the poll, so I'm not sure if anyone else on our.
Hi, Andrea, this is me. I'm so sorry. I don't. Let's see if I can get this pulled up.
Here we go.
Here we go. Is it up now?
Yeah.
Yes.
Great. Thank you.
Okay, so when should you begin the advanced care planning? At diagnosis, during the treatment of chronic disease, after the treatment, or when the patient transitions to hospice? Okay. Very good. And the answer is at diagnoses of a chronic disease. That's when we need to start having these conversations. That's right. Wonderful.
Great. Thank you, Rachel. All right, so just some additional resources and information for you all. These are included in the PowerPoint that we've included in the chat. So if you want to access any of these links, it's available to you there. We have our Shine a Light on Stigma campaign. So if you're interested in taking the pledge, we ask that you take a moment to go ahead and do that. We always love to continue the conversation with you through our Superior Health Connect platform, which is where we post a lot of great resources in there. So the link to access that platform is located here. We also have a couple of other great resources and information for you, some documentation and coding guides related to a few of our chronic disease topics and our Food First Using Food as Medicine information. And just a reminder that our next sessions coming up over the next few months are they're outlined on this slide. So we'll be covering part 2 of advanced care planning next month, nutrition and tobacco cessation in the coming months as well. Again, we'd love to continue the conversation. So just a reminder, if you are not already in Superior Health Connect, we encourage you to do so and get signed up so you can get access to some of our resources that we have available to you there. But just some final next steps. Obviously, if you've registered for the webinar today, you should have received the invites for the remainder of the series. We do encourage you to share this with the rest of your team. So please go ahead and do that. Again, signing up for Superior Health Connect. And if you would like any more individualized assistance, please feel free to reach out to us. Jerry's email is listed on this slide. If you have any questions, comments, we'd love to hear from you. So that's listed on this slide. But with that, I think we will go ahead and wrap up for today. Thank you so much for joining us, and we will see you next month for part 2 of our advanced care planning presentation. Thanks, everyone.